Hello, today's topic is digital healthcare. Today I'm going to give you it from the perspective of computer science or computer engineering from a technical perspective, so to say, or applications or IoT architect, if you will. That's one position that I've held before. So I'm not a medical doctor. I'm a doctor. I have a PhD in computer science. So what does that mean? That means that I know how to build all kinds of sensors. I know how to write software for them. I know how to build applications. But I also know how to deploy these systems and also how to design systems for different purposes, including healthcare. So I've been doing this with sensors in different kinds of environments on a remote island in an Atlantic Ocean. However, these pictures, the picture on the bottom to the bottom right, is from the edge of the top of the Kilimanjaro. That's the highest place in Africa, the highest mountain, if you will, right? And when I was climbing up there, the oxygen in the air seems to be less and less, and it's not quite the case that the oxygen is lower, but the partial pressure is lower, and therefore our bodies have trouble acquiring enough oxygen sometimes. So it was pretty tough. And then I was thinking, hey, wouldn't it be nice if I had a sensor that tells me, whether I'm okay. On one hand, it would be nice to monitor my health as I'm ascending there, right? On the other hand, if I were to monitor it, I wonder if I were ever made it to the top, because it was pretty tough. I mean, I did survive. I didn't get sick. There are some people that cannot get to the top because of the oxygen deficiency, so they have to turn around and climb down. That's the only way how to do it. Anyway, so that made me think about all kinds of sensors and applications in medical environment. At the top of the picture, you could see me on a snow. It's not a snowboard, right? On a snow motorcycle. I was part of ski patrol at the time while I was doing my studies, my PhD studies at the University of Pittsburgh. I also did study a little bit of how to take care, how to deal with emergency medicine, how to help people that are in trouble because of a skiing accident, or actually anything that could happen within 7 miles of that resort. So that includes even in swimming pool, or even in the hotel rooms or wherever. So I have had a little bit of training from that perspective, but I have worked with medical with clinicians, with people that are nurses and doctors, and we have had great experience. So I'm going to tell you today what I have learned and what my views on the subject are. So I have shown this picture before. The purpose of it is to introduce a macroscope. Basically, we know what a microscope is, most likely. We better know what it is, right? Microscope has been invented about 400 bit more years ago, I believe. And it has allowed us to create many different things for medicine, for all kinds of areas of science or applied techniques. So macroscope, however, is something that tries to look from above to get the big picture, right? So we could, measure different locations on a redwood tree, or in any environment, in a city, on a person, in a room, in a hospital, in school, as we will see today, and try to figure out not just, okay, what is the temperature right there in that one location, but what really is going on in that environment, right? So, and today I'm going to talk about how to apply that for improving healthcare. All right. So let me show you what I mean by this. All right. So usually when we go to a doctor, we have. I should switch to the smaller picture here so that you can actually see what I'm talking about here, right? So when we go to a doctor, the doctor is asking, so what's your problem? And I'm saying, oh, I'm having a headache. And the doctor says, all right, so let's go take blood sample. So about a day or two later, I go and take a blood sample. And then about, maybe another 2 or so days later, I go back to the doctor, and the doctor looks at the blood sample and says, okay, so it looks like there's this problem. So let me prescribe you this medicine. Right? So I'm taking that medicine, and it seems to help, but not quite. So I'm going back to the doctor, and the doctor says, okay, so let me take another test of, let me measure this or that. So the doctor is sort of acquiring points, like pixels in a picture of my health, right? But the way it's been done so far, I think is not sufficient enough. So if we are just taking a few points of a picture, then what we're getting some sort of a view on it, but it doesn't, behind me, it doesn't tell us much. What does it look like? It looks like a hill or something, right? And as we are taking more measurements, if you will, we may see some, money in the picture, or some wow, or something else. So let's take a few more measurements. And the more measurements we take, the fuller the picture becomes, right? And the more we can tell about the picture, what is happening, what could really be going on with our, health, or in this particular case, what could the picture be, right? And turns out this is a, pretty beautiful picture. It's a classic one. There's a lot of story behind this picture. And if we can see the whole picture, then we can see the whole story. Otherwise, I could see just a couple of points, and then I can just try and guess, okay, let me try to take this medicine or that medicine, or maybe there's, I don't know what's going on there, right? So technology can help us to take many more of these pixels to acquire this whole big picture of our health, all right? So let me give you a couple examples. So let's say we're going to a doctor's. What's the world that the doctor has to deal with? So nowadays doctors have a lot of patients. There's a large volume. So a family practitioner, in Latvia at least, it's not surprising if he has or she has 2,000 of them or so. So that's a lot to remember, if you even can remember this many people, right? To remember everybody's health. Of course, there are some records. There can be records on the paper. There can be electronic records, and then you can look them up. But then again, it's a lot, right? It's a lot going on. So sometimes when you're looking at the history of the patient, you think, okay, maybe we need to do a checkup on this person. Maybe he had an operation not too long ago. Maybe we should check whether, the health is all fine now. But maybe we forgot to do that, right? Because we have so many patients, because there's so much going on, right? So there's a failure to follow up to the history, right? There could also be the deficiency of electronic medical records. That's even if you have electronic medical records enabled, or if they are state of the art, right? So there might not be all the information. Sometimes when I'm going to one hospital, they're taking the x-rays. Then I'm going to another one. They don't have access to my x-rays from the first one, perhaps, right? If the system is not quite well in the place. It would be nice for us to have, full history that follows us, right? And in many cases, the patient is a stranger to a doctor. So the patient comes in. This is the first time the doctor sees the patient. Yes, we can have a conversation. But there's a lot about me as a patient that the doctor doesn't really know about my history, and even what my medical records maybe do not disclose. Right? As a result, and of course, well, there's another aspect that the doctors are humans, and there's a human factor. We all make mistakes. We are tired. We don't ever always see everything, every little detail. Sometimes things get mixed up. As a result, there's a statistics that about 150,000 Americans get misdiagnosed every year. So that's coming from the Journal of American Medical Association. All right, that's a little bit disturbing, isn't it? So that so many people have their diagnosis mixed up with something else, right? And as a result, 1 in 3 of those patients die or are debilitated. So there are dire consequences to these mistakes. What is this 1 in 3? So that's about 40 to 80,000. That's a lot of people that are dying because of some mistakes. So what can we do about it? Right? And one way to do is to apply the technology to go towards the digital health. So what is digital health? So let's see. Let's go through a couple of cases and see what could it be or what could it become, right? So as part of technology, we have a lot of sensors available to us today. There are sensors we can place in the environment. So we have sensors measuring the temperature, humidity, and see whether it's all healthy for us. We have smartphones all over the place today. Everyone virtually has a smartphone, right? And those smartphones, they may be in our pocket, in our little bag, little purse, or in our hand, on our body. We have smart watches these days, fitness bands, and all kinds of sensors all around us and on us, right? And they can be simple, and they can also be very sophisticated. They can be very custom made. For example, there's a sensor on the right top picture here that's attached to a cup. So this sensor is for professional sports, American football players, I believe, and it's monitoring whether the person is having a concussion or not. Because during the game there can be all kinds of rough play, especially for American football and many other sports, right? And the player itself, it may say, no, I'm fine. But if there is a serious possibility of injury, then maybe this sensor can detect that faster and raise an alert and say, hey, we have to go to the hospital. And there are also sensors such as here on the bottom picture that are very light, very unobtrusive. So this one is monitoring I believe the temperature of a little baby that's just sleeping there, right? And we can monitor it. We can see whether everything is fine, because the baby cannot even tell us that something's wrong or that what exactly is wrong with them, right? So there are going to be a couple examples that I have encountered. So this one comes from the Institute of Electronics and Computer Science in Latvia. It's a smart fabric. So what you could do, you could create a vest or a jacket and put it on a person, like in this picture. So what this vest can do, it has a lot of sensors. Let's say it has about 60 sensors on it in a grid. So it can sense the movement of that fabric, and it can tell whether the back is straight or maybe crooked. So this project started after we discussed scoliosis with some doctors, and we were thinking, what could we do? How can we help people that have this problem, right? So one solution is to create what's called a corset. So basically, that is something that the person wears every day, and that kind of keeps the person's back straight, right? And it's custom made for every person. It's not very convenient. It may hurt, it may bruise a little, so it's not nice, right? At the same time, we could have a flexible jacket like this one, and that could tell us, hey, you're crooked, you need to straighten up, right? Or you've been sitting too long, or maybe something else is wrong with your dynamics of your body, so maybe you need to change your position or something else. So that's one example, right? So another one is actually using the same kind of sensors, the accelerometers that are on a chain, so to say, on a string of wires, for knee rehabilitation. So this is one of my ex-students in his thesis work. He created this system that would monitor how a person is flexing the knee. So let's say there was an operation on the knee. So what this system could do, it can monitor in real time as the person is exercising. So usually in this situation, people are a little bit afraid to do too much exercise. As the result, the recovery is not so good. On the other hand, if the person is doing way too much or flexing too much the leg or doing something else, then the sensor can tell the person, hey, calm down, so you're gonna injure yourself, you're not ready for that yet, right? So again, once again, so till now there have been mechanical devices that sort of inhibit the range of movement for that joint, but we can augment them with the sensors so that they become dynamically adaptable to the person or to the situation. They can report to the person, give immediate feedback about, hey, you're doing good, keep on working out, for example, or wait, you need to slow down, right? So there can be, this is another project where we created these, you could think these are huge bracelets, if you could even call them bracelets. It's not even a smartwatch. So what this is a super duper special device for super kids. So like a Superman may have all kinds of gadgets, this is the gadget for super kids. So it turns out kids don't really need always tiny and shiny and small things to wear. They sometimes prefer something big and bulky that makes them feel like a superhero or something, right? And also encourages them to work out, for example, right? At the same time, this device, it may encourage this kid to do exercises. It may measure whether he is doing properly these exercises, and also may introduce some sort of gamification, right? Competition with other kids that are not in the same room, but that are also participating in this competition. And sensors can also save lives. So this is the story about, or two stories actually, about smartwatches from, I believe, Apple. These are where people got their health and actually lives saved because the smartwatch was monitoring the heart rate for a longer time for these people, and noticed that there is a problem, that something doesn't look quite right. And they alerted the people that are wearing those watches. The people would go for a medical checkup, and they would figure out that, hey, there's a problem. So in one case, this was a blood clot in his lung that was eventually, successfully removed. So, or a lot of things in our bodies can be detected using just simple sensors and fairly sophisticated data analysis, right? And if we were to rely just on a, let's say, yearly checkup with a doctor, we may, not notice these problems. So this is where technology can come in, and the technology can help, right? And even if you're saying, hey, it's bulky and not convenient to wear those watches all the time, and I'm gonna forget them anyway, or I'm gonna, for example, if we are going to bed, we're going to sleep at night, I don't want to wear anything, right? So there are sensors that can measure these things via distance, right? Or via vibrations. So for example, there are a couple sensors such as EarlySense or mFit or Nokia Sleep. It's not under Nokia anymore though. What was the name of that company? Well, anyway, what this is like a little strip, such as in this picture, that you place under the mattress, not even under the sheet on the mattress, but under the mattress. And turns out, as we sleep through the night, we breathe, we have a heart rate, we move around. So all of that introduces vibrations, some sort of movement in the mattress. And this movement can be detected by these sensors, right? And this data can be sent for analysis either to our smartphone or perhaps to a server that can do more sophisticated analysis. And not just, for that particular moment in time, but actually for an extended period of time, and see what our baseline is. And then it can also tell us, okay, hey, something is going on. We should probably check up your health because for the last couple of weeks, there is something strange going on with your heart rate at night, right? So it's lower than usual, for example, or maybe vice versa, right? So I also know that there are sportists that are using this system to prepare for training sessions, to see what kind of load they can put on their body, depending on what the stress levels of the body have been, right? And also there's a list of effects that were measured in a case study when these sensors were placed in a real hospital. So this is in California hospital, medical center. And the effects are amazingly good, since these sensors were there were 0 patient falls, 0 pressure ulcers. That is a big problem actually for patients that are laying in the bed and not moving or not able to move in the bed, and therefore they may develop these pressure ulcers. So medical personnel may need to come in and move them around once in a while. So these sensors can monitor this movement. If the patient is moving on its own, then great. If the patient has not been moving for a longer time, then we can call a nurse, and the nurse can help the patient, right? And all kinds of early detections of different health problems, such as sepsis or blood clots or cardiac arrhythmia and so on. So basically, these sensors are saving lives, right? And they can do it in an unobtrusive way. Of course, sensors is just part of the story. The other part of the story is proper data analytics, right? So now that we have seen a few use cases, what is digital health, right? So you could say, hey, this is the answer, right? This is the word map, so to say, with all kinds of terms that are used in connection with digital health, right? So privacy is a big one. Data and medical are the 2 biggest, but the privacy is just there. Well, see, there is this picture as well, right? Health is big, time, diseases, and so on, right? But if we were to formalize that a little bit, and actually the funny thing is that in this big picture, if we look at the word sensors, that's a fairly tiny one, actually, right? It still made it here. It's still bigger than business, funny enough, right? And guess is a really small one. See, that's kind of what's telling about what the digital health is. So if we want to look at it a little more defined, then the digital health, you could say, is a collection of wireless sensors and devices, and I must say analytics as well. It's also about genomics. More and more we can learn from the genomics of people, right? It's about social networking. How is that? Well, we quite often can, when we're feeling good or when we're feeling not so well, we sometimes send messages to a social network. And there could also be some analysis placed there, of course, with the privacy strongly in place, that may, add this information to the analytics for the whole picture of our health. It's about mobile connectivity, which enables us to be followed, to follow our data as we are moving around the world, wherever we're moving. So we're going to see one project today that I'm going to talk about that follows the patient, and the patient can just go and work out wherever she or he pleases. Right? It's about imaging and analysis of imaging, be it X-rays or be it the video that we are taking or looking at within the habitat of the person or in the workplace of a person, and get valuable information out of that. So again, there's going to be a story about that today, where we're monitoring distance between people to minimize the risk of infection, and that's using the video analysis. Health information systems. So certainly if we have all this data, it has to be meaningfully organized and accessible at the right time by authorized parties, right? And once again with privacy firmly intact. Well, internet allows us to travel and to access information not just about our health, but also about what's going on in the world. So including what are the longitudinal studies about this or that disease or group of patients, and how can that help with my health, right? And also about, nowadays pandemic is a big thing. Even before, when there were, smaller flu outbreaks here or there, we could, monitor that through social networking and also through the internet connections, to see, what could be the cause of that pandemic, or is it localized? Maybe we can somehow, react to that from the governance, not just individually from the doctors, but even from the government, if you will. Okay. And of course, we need a lot of computing power to do all this analytics in the data universe, and we need access to the data universe where all the knowledge would be stored, and the history, not just our history, but the history at large of people, so that we can learn from that and apply it to benefit our health. Right. So as a result, what are the benefits? Things become more efficient, and the access to the data should be more easy and even unobtrusive, right? It's just like today, when I'm walking around, I'm never, worrying about, hey, what if someone calls me? I just take my phone with me. So that wouldn't be the case about 40 years ago, right? There were no cell phones. So nowadays we have that technology, and it's just a given. We're not even thinking about it, right? So by the same token, why don't we have similar things for our health, aided by technology, right? And here on the right side, you can see, maybe I can switch myself off a little so that you can actually read what's written here. What are the benefits for the patient, for the family? So the patient gets better care, more safety. As we are aging, we need more and more health care, and we are more and more at risk, unfortunately, with our health. So this technology may allow us to actually live and age at home. We don't have to go to, nursing homes necessarily. So we can still have the sensor systems monitoring our health and aiding our health. And the family, therefore, also gets comfort about health of their relatives that may not live with them together. I mean, for example, once you get married, you probably move out of your mother's or father's house and live somewhere else. But you still care about the health of your parents, right? So this system may provide benefits for that as well. On the other hand, the medics get the opportunity for higher quality of the care with all the tools that are provided. Insurance may decrease the costs because now the risk is also decreased, right? And a health institution can also provide better service through all these technological opportunities. All right? All right. So I'm going to go through a couple of projects of mine as case studies now. So there are going to be 3 projects. And the first one is about diabetes. So diabetes is a huge problem, one of the biggest problems for health care, for health-wise. One of every 11 people in the world, of adults, have diabetes. So that's according to the World Health Organization, right? And different countries may have different, percentage in diabetes, but not just the percentage of population, but also in the percentage of how is it increasing year by year. So, for example, in Latvia, we have not even 2 million of population, but at the same time, every year we have, 4,000 to 6,000 new, well, actually more like 4,000 new diabetes patients admitted. And that's crazy, right? Unfortunately, there is no cure for diabetes today, but there are ways how to mitigate this health condition and provide a healthier life for people that are unfortunate to live with this or unfortunate to have acquired this. All right. Also, I need to mention that there are several kinds of diabetes. So there is the type 1 and type 2 diabetes. Usually the type 2 is acquired later in life, and it may not require taking the blood sample every day and so on, right? But you can change your lifestyle if you have type 2 diabetes. have it more active, and this way you can modify your body's functional health in a positive way. So that was what the project was about. And the question of the project was, can we apply high intensity interval training to diabetes patients, and would that have a positive impact to their health? And there have been studies already. So this one, for example, is from a paper even in 2015 that observed that if a diabetes patient has regular high intensity interval training, then the blood glucose goes generally down. I mean, it is still high, but it's not as high as it was before. See, before high intensity interval training, it went up to 16 millimoles on liters. So that's the measurement that we are having in this paper anyway. I know that in the world there are two systems for measuring blood glucose. But anyway, the point is it went way down to about 12 or so. So that's in the morning anyway, right? When the blood goes up, blood sugar when it goes up. So there is a potential. Now, how can we enable for people to take advantage of this potential? And our approach was to create a virtual trainer, basically to create an application on a smartphone that would become a virtual trainer for a person to do high intensity interval training, right? So once again, what is a high intensity interval training? If we look back to this picture, it's sort of like, okay, let's run real fast for 1 minute, then let's walk for 1 minute to cool down, so to say, and then again for another minute we run real fast, right? So this is not about how fast we run, but this is about the zone of the heart rate to get up for our body. And if we do it long enough, for example, if we do it 3 times a week for about 4 months, and if each training session is about 40 minutes, then the hypothesis was that there's going to be a positive long-term effects on the biomarkers, on certain biomarkers for diabetes 2 patients, right? So we had a group of fairly elderly people between, I think the youngest was maybe 35, but up to 70 or even 75. And at that age, and also with diabetes, quite often people cannot do, heavy sports. So we would say, why don't you walk? We would call in every patient to do what's called a VO2 max analysis and measurement to see what are the desired heart rate zones for the person, so that the person would most efficiently function. And then we would incorporate those zones into the application, and that application would monitor the heart rate. So the person has not only the smartphone with him, but also would have this little. The person would also have this little belt around the chest here, right? And this belt has a heart rate sensor. In this case, this is Polar H10, I believe. So that sensor would talk to the smartphone, and the smartphone would make decisions. Okay, so now your heart rate is okay, so you're doing good, or now you should walk faster, or now you should kind of slow down, right? So that's sort of virtual trainer. So we had a group of 60 people. We had 20 people in the control group, so they would do as they usually live, right? So no change there. And then we would have 20 people that would work out with a trainer, real live person, and then another 20 that would work with a virtual trainer. Eventually, though, those 40 last people, all of them used the virtual trainer. So that was the group for this particular project. So there is text in Latvian, because this is just a screenshot from the instruction that people would get. They would get a complete set of blood glucose meter and the smartphone and the sensor, the belt sensor. They would also get the account and on this particular smartphone, so that the data could be downloaded real time to the cloud. and eventually analyzed. All right. So there were a lot of parameters, about 100 plus parameters that we measured. The most popular ones would be the age, weight, and BMI, and so on. So if we look at the age group, so you can see that 62, 64, that's the sort of the peak where most of the people were in this group. If we look at the weight, so the weight is pretty much between 60 and 115 kilograms. So, and it's fairly evenly distributed here. So with some even up to 146. So that is kind of the issue, if you will, with people that have diabetes, that quite often the weight also goes up, right? Sometimes it's because of the diabetes, and sometimes the diabetes is because of the gain of the weight due to too many sweets and whatnot, right? But it has to, be looked at individually from person to person. And so on. All kinds of other indexes were there. Right. Okay. So one of them was this HbA1c index that I think has to do with how fast can you process the glucose in the blood, but I might not be precise enough now saying that. Now this is included because this was one of the parameters that actually improved after the interval training, as we found out in this study. So this is how the data looks like after we have collected. So this is due to the course of 4 months was done. We could see when in time the trainings would take place, right? And we could also see the blood glucose measurements at the bottom. So if you are an endocrinologist, then you could see this data and analyze it and make some decisions based off it. And you could actually look at this data in real time. So let's say if we are just halfway through the summer, we could see all the history up till then and all the newest history, right? This might not be as interesting, actually. What's more interesting is the actual data when you go through the training, right? So this is one training session. We're looking at the heart rate data here. The upper and the lower edges of this colored belt are the heart rate target zones. So basically this is for the high heart rate and this is for the low heart rate target zone. Each particular person would have individual, personalized heart rate target zone, right? And the whole training session would be divided in the warm-up phase, and then the training would start by having the high interval, low interval, high interval, low interval, and so on, right? All the way down to about 40 minutes, and then you could have a cool down as well, right? So we would monitor, and the patient also would monitor this. The patient would not see this line, but the patient would get suggestions such as, okay, go faster or cool down, or you're doing good, and things like that. And this could be done in different modalities. So it could be seen on the screen, or it could be heard in the headphones. So that's another connection through Bluetooth. So you can have a lot of technology around the person, but you should not burden the person. You should really make it unobtrusive for the person, All right. So what did we discover? Compliance is a big problem, right? So there are people who would, do training at the start, and then the summer began, and they all of a sudden they felt like they don't need it, or they had, some more important things to do in life. Of course, the participation was voluntary in this study, right? And also we had to involve people that do not have serious health complications other than diabetes, right? So that we would not put them at risk. Let's say if the person has a heart disease, he would not participate in this study. So anyway, compliance. Sometimes people would just do it at the beginning. Sometimes they would not do much in the beginning, but at the end they would say, "Oh yes, I can do it now. Let me do it now," right? For the last month or two. Some people would just do it occasionally, while they would just participate in the training sessions occasionally. And some people would do it intermittently. So, for example, they would do 1 month, then they would have a pause of 1 month, then they would have another month. So the goal would be for people to do these training sessions over the course of 4 months consistently. And only if that's what they do, only then we can extract meaningful data, right? So turns out the study was not just about, hey, can we improve the health, but it was about discovering what the bottlenecks, what the roadblocks are for applying digital health in this particular case, right? So here are a couple of examples. So at the top, we would have the target. This is how the actual line should look like. You know, we have the interval with the high heart rate, then with the lower heart rate, with the high heart rate, lower, and so on, right? So this person for this training session did very well, and good job, right? Now, if we look at another one, so here you can see that the heart rate goes up and it never goes down. So this person they could not cool down their heart for the rest periods. So was it because they did not walk slow? Or was it because, you know, their body would not be adapted so well? It's a bit hard to tell at this point, right? So then some people would start the session well, and then they would drop the second half of the session for whatever reason. So this could be that the person decided, oh, that's enough for me, I'm just going home. Or this could be the sensor malfunction as well. So there are this kind of issues that you also need to monitor for when dealing with digital health systems, right? Or especially when you're designing digital health systems. And finally, well, there's a picture where the heart rate for the person never reached, well, actually once it reached to the zone, but not even the high zone, barely crossed the low heart rate zone, and it was pretty much living in the 80s. So this person most likely did not train. Maybe the person walked, maybe the person just sat. I don't know. That's pretty low heart rate. It's certainly not complying with the requirements of a successful interval training session. All right. We also discovered interesting things. So these three graphs are for the same person. In May, there was the case when the heart rate would go up and it would stay very high for this person. Okay. So the person could not really drop the heart rate to the minimum level for whatever reason. So after a couple months, we are observing that in the beginning it's high, but as the training session goes on, then somehow the heart rate starts to fall, to go lower, right? So it's still not going to the lowest desired zone for the person, but at least the shape of the data starts to show a promise in the training for this person. And again, a couple of months later, in September, the data actually starts looking like a fairly good training session for this person. So the moral of the story is that turns out this kind of approach, this kind of virtual trainer may help person to learn how to control your body, how to control your heart rate, how to perform training sessions efficiently, right? So I think that's a good benefit. That was kind of unexpected benefit from this study, but that's what we got. All right. So if you care about the particular statistically meaningful results, then here they are. What we noticed that VO2 peak measurements would improve for people. Albuminuria, I believe, also had improvement, and total cholesterol sort of maybe improved a little bit. See, we have the control group in these graphs and the intervention group. So intervention is the dashed version, and that's how we can see these things. So in fact, the VO2 peak improved for both groups somehow. So that's not really something that we can brag about too much, right? But albuminuria went down, especially for those people that did train, and did not change much for the people who did not, right? For the control group. And this HbA1c index, well, that also improved. Okay, so that's good news. So that basically tells that interval training can help, and having a virtual trainer, a digital health solution, can help people, can help to scale this. It's not a treatment really, but this kind of activity. Not everyone can have a personal human trainer, or even to participate in group training sessions, if you will, right? But this allows you to go on your own time in your own place. So people, there was a participant who actually went on a business trip over the border somewhere else, and he would still do these exercises. So you don't have to be at home. You don't even have to be in your home country, as long as you have your virtual trainer with you. So that's good. Now the problem is motivation and compliance. So that's a big problem, how to motivate people, especially how to keep on going this motivation. And that's something that everyone needs to work on in this field anyway, right? And then, of course, there were some technical conclusions as well. For example, it's very tempting to use a free service. So Google has this Firebase cloud, and up to a certain data rate and an amount of data, you can have it for free for a certain number of time. So that's what we did. That's what we used. But unfortunately, at the end of 1 month, it turned out that the data rate limits were exceeded, and therefore the data just disappeared for the rest of the month. So that was unfortunate, right? So that also taught us that, number one, if you want to do things reliably, then you need to actually pay for that, right? You need to purchase a reliable service with guarantees. And the other is that you do need to have a 2-level data storage for backup. So one is in the cloud, but also have a local backup so that you could recover that data. And we kind of had that for our application. So that was, again, fortunate. So we could recover the data after that fact. Of course, we could not have the real-time data at the time when there was outage in the cloud, but at least we could analyze the data later. So those are a couple of lessons learned for this project. Okay, so the next project is going to be about the Opera. Well, not just about the Opera. In fact, it's going to be about minimizing the infection risks using contact tracing. So what is contact tracing? Contact tracing is when we try to figure out who has been in contact with whom, for how long a time, for how long a distance. So something like that, right? And at the same time, we want to do it while abiding the privacy laws. So that's kind of tricky. We need quite precise measurements, but at the same time, we need to have access to the data to do the analytics. So let's see what we did and how we did it. All right. So this was one of the projects that's sponsored by our government during the pandemic. I believe that was the last year, not this year, but the one before. Started in fall, summer, fall, right? So we had a fairly big group of scientists, of doctors, of anthropologists that would conduct interviews with the participants, and computer scientists, including myself, and also students, right? Including the students here at the bottom. Those are my favorite students from my group. I'm really helpful and grateful for them to actually participate in this project. So I believe a lot of good came out of it thanks to them, thanks to their hard work. Right? So the project had many goals actually, but the focus for this talk is to access and develop evidence-based strategies to prevent transmissions in high-risk indoor settings, the transmissions of infection, of a virus such as the COVID-19, right? And we know that COVID-19 is an airborne infection, so it travels through the air as we speak, as we cough, as we yell, as we sing. So there are all kinds of activities how we can transmit our virus to the rest of the world. So to minimize that infection risk, we all know that the good distance is actually what's required. so that we could not perceive this cloud of viruses coming from other people. Well, it's not gonna save us 100%, unfortunately, but it will certainly, minimize the risks of infection if we can control that somehow, or at least warn the people about that they are in this risk, or to tell the management where are the risk zones in that particular environment, right? And maybe they need to rearrange, I don't know, the furniture or make bigger rooms or something else. All right. So contact tracing, what are the parameters here, right? So we need to figure out, I'm not sure in Ukraine what was the requirement for the distancings, but in Latvia it was 2 meters, and no longer than, if it's 2 meters and longer than 15 minutes, then you are very likely to have a virus. So that was sort of the baseline that we tried to follow. Were those numbers the same for you guys? Okay, so they were the same for you. Clear. All right, but in our case, we have this application that's called Apturi-COVID. It's a Stop COVID application that anyone can load on their phones, and it would silently, quietly monitor the distances between you and anyone else who has that application, whether it's a supermarket or anywhere else, right? And if there has been a contact risk, if someone got the infection, actually got the COVID virus, and would report that, then anonymously other people who were in contact for this distance and the time would get alert that, hey, you have had a contact, please go and check your health. All right, please do the COVID test. That was the idea. And one could say, well, we have this application, why else, what else needs to be done? So in this case, the application actually is not that precise. The kind of technology we have in our phones, it has Bluetooth transmission and reception devices, so it can kind of estimate the distance, and plus minus at 2 meters it could tell you, but it's not going to be on the centimeter or not even at the 10 centimeters precision, right? So for the more precise study, we would really need more precision. Also, in this case, it's very anonymous for preserving the privacy, of course, right? So it's not going to tell us where this, contact was or between which times of the day, right? For this study, again, we need that. So we had to have a different kind of technical solution, more precision, more information, the location information, where the hotspots are in the space, and also in the time that we could not get from this up to the Stop COVID application, right? So that's what we did. We created the solutions like that, and we went to 4 different kinds of environments. To the National Opera House, they had the training sessions, the repetitions, so to say. The concerts at the time were not publicly allowed, but they would still, train, exercise, and they would record performance for the New Year's, for example, and so on. Right? We went to school, but the school was on one hand kind of very busy. On the other hand, the at the time school children would study from home already, right? So we couldn't monitor them really because they were not there. We went to a hospital. So this is a children's hospital. One of the hospitals in Riga, Latvia. And then we went to a factory. So this factory is making bathtubs, if you will, right? And these are the environments where we placed our solutions and try to figure out what are the hot spots on hot zones for where the contact, the risk contacts happen, really, right? So again, these are 2 screenshots from the kind of documents that we gave to the participants. That's why they are in Latvian. But essentially what they say is that this is what the study does. We have a device. The device collects data, and this data is anonymous, so we will not know who you are. We will not report to anyone what we have learned. And we had 2 kinds of methods. So one was creating smart cameras, video analysis, and the other was using smart sensors, basically something that you carry with you, and that would provide more precision than cameras. All right. But once again, everything was very much privacy preserving, because we don't want to intrude into people's lives, but we need to figure out where are the problematic areas in the environment, and then we relay that to the management of that environment, and then the management can decide what to do about it. All right. So we'll see in practice how it happens. So first, let's talk about smart cameras. Smart cameras use the YOLO, which is you only look once type of algorithm that would look at the picture, and then it would try to recognize where the human bodies are and place sort of a rectangle about those bodies. So here we have just red dots of where the people are, and from that we can actually calculate where the coordinates of the people are in this environment, and from that we can figure out, okay, how close they are to each other in time. All right. So this kind of solution, it would not save the picture, so this picture is actually taken offline, right? It would just save the data of these registered contacts, right? Again, this is due to the privacy, even more than due to the, otherwise we need a lot of storage to save all that video data. So there was a challenge, several challenges, okay? All right, so there were several challenges. One of them was for the setup of the system. So it turns out sometimes the good tripod is more expensive than the camera itself. And it's not always easy to get to those locations, because by default, they're not expecting to have cameras in that environment. So this particular location, I believe, is in the children's hospital. So we had to go up to the ceiling and to figure out. So this system would have actually two cameras, I believe, sort of create a stereo vision to extract the coordinates better. I think that was the solution here. Also always needs stairs to get up close to the ceiling, and that's sometimes it's a challenge to get those stairs. Other challenges are that, in order for a camera to operate for a long time, it needs a lot of power. So therefore, we do need to plug it in into the 220 volts in Latvia. That's what our power network has, right? So, and here we have a couple of pictures. These pictures are from the factory, but here on the right there's a picture from the opera house. So this is the orchestra pit, I think that's what it's called, where the performers would sit and make music. All right. And also the actual solution, the methodology had all kinds of issues. So for example, when you have these, rectangles on the screen, where exactly are the feet for those rectangles, and where are they really touching the floor? That's one question, how to figure it out in a meaningful way. What to do with the mirrors, right? If there's a mirror in the room, then the mirror is reflecting the person, and all of a sudden we have two people that are really close to each other. Turns out the same person, but hey, how did we know, right? The camera didn't know that. And there might be some other things that are recognized as people. So if there's a box that for some reason it's moving, it thinks, oh, there's a person there, right? So it's quite challenging to build a system like that. So the result of such a system would be as described. There's a map, for example, with the coordinates of where the people were on that map. And we could also, if we aggregate that over time, we could create what's called heat maps, and we would see that this is the area sort of where most of the time either this person has people are kind of hanging out there, so maybe there's a coffee machine there or something else that attracts people, right? And that since it attracts people, then there's a more chance for infection as well. All right. So on the other hand, we had the smart sensors, and these are like these tiny boxes. We had two kinds. We had the Helico system that's made in Estonia, I believe, and then we had Decawave system that comes from Decawave company in US, I believe. So either way, the way this system works, you have a sensor, let's say, around your arm, in a pocket that's the same pocket that you could use for smartphone. And this sensor is talking to the anchors that are attached to the walls. So maybe a room has 4 anchors. And by talking wirelessly, basically it's using radio communication, it can calculate where the coordinates are with very high precision of that sensor and consequently of that person, right? So that's the idea there, to get the coordinates of the people in real time, the people that are wearing the sensors. Of course, we gave the sensors only to the people who would agree to participate, right? There were people who would not agree, then they could do whatever they want. All right. Again, deployment challenges are to figure out where to actually place those sensors, but the good news is that we can run everything on batteries. So we don't have that issue that the cameras had. So these are the anchors on the right side. So these are kind of the antennas in the room, or in this case, in the opera house behind the stage. And the actual sensors are either these or these little ones, right? That the people could have around their arm or around their neck or in any other ways. So the results, this is the Children's Hospital. We gave the sensors to the doctors as well, not just to the patients. And we found out, for example, that there's a fairly small room, maybe 3 by 5 meters, and they have a lot of people there. And there's a lot of infection risk there among the hospital workers, actually, right? So of course, we told about that to the management. They kind of knew that already, but here's the data. That's the evidence. So they have to do something to figure it out. At the same time, for example, in the big hall where the rehabilitative physical exercises were performed, there was no issue with risk of infections. There was another room where the hospital personnel would go and sort of rest, have a lunch, or have coffee or something like that. So this is also one of the critical areas, obviously, where infection can occur. And now the big room here in between, this one was the room where patients would wait for their turn to get to the doctor, for example. So it wasn't too bad, actually, here. And there were not too many people there either. So on one hand, the results were pretty good. Now the other area that we did this was in the opera. So here the repetition actually takes place in the room where the spectators where the people usually sit that are watching the concert or the opera, right? Or the ballet. Except they took out all of the chairs because this room is much wider, much bigger, and therefore they can make this distance between the artists much better, right? I'm gonna have data about this one that I'm gonna show you in a moment, right? And we could also monitor the people, even the people that are on the balcony here, because the system works in 3 dimensions, right? So the results. And this picture on the right, where we see a lot of dots in different colors. So every color is a separate person, all right? And so these paths are kind of how the person has moved. So this picture doesn't tell us that much. It just tells us that on the left side and on the right side of the stage, so this whole area is a stage, actually, right? At the bottom, this is the seating area where the people are watching. And on the top, this is the stage. So it turns out the stage is just as big as the seating area. That was a bit of a surprise to me, but hey, we always learn something. So anyway, the right side is busy, the left side is busy. So maybe these are the risk areas, right? Except in this picture, every dot is just a single person. So therefore, we can do a calculation that actually analyze and make a dot to become a pair of 2 people, and only then when those people are closer than 1.5 meters for more than 5 minutes in this case. So there we see that still the right side is a little busy here, but the left side is definitely busy, right? And a little bit here in the center. And then if we run it for 15 minutes, then turns out that for 15 minutes, the right side is not really a problem. The left side is though, right? And we did tell that to the management of the opera house. And I hope that they have taken care of that issue here, right? So this is the actionable data that you can actually use to improve the health of people. So kind of interesting aspect here is that we're not really talking about heart rates, about temperature of the body, anything like that. We're actually monitoring the movement of people in the room and not talking about one person, but we're talking about the group, about the social aspect here, or the business aspect in this case, what they have to do in order to work there. And we can find out things. So we found out that 2 pairs are at high risk contact. We don't know who they were because it's a privacy issue, but at least we know where the locations are and how to take care of that. So when comparing the 2 solutions, video and the sensors, we found out that the camera is good because the people don't have to wear anything, right? They just appear there, right? That could be good for large venues, let's say a performances theater or some public events where people just come in and then we can sort of monitor how things are happening and then report later to the management so that they can see how to do the crowd management there. However, the precision was not that high due to the fact that the camera has certain angle. It doesn't see everything. The farther the people are, the less precision there is for the camera because the pixels kind of go farther away from each other with longer distances. And also it was quite sensitive to dynamic light changes, which could be fine in one environment such as the hospital because the light there is pretty much constant all the time. But if you are on the stage of a performance on the opera, then it can get crazy there. So then this camera is not going to help you much. So for those kind of occasions, we can use the smart sensors with a high precision. However, the people must agree to wear the sensors and they must wear them. And this could get in the way, especially for the musicians that are playing violin. They don't want anything on their shoulder or close to the shoulder. Maybe they can have it around the neck. Maybe they can have it somewhere else. But that's a challenge anyway, right? So both solutions are good, but each of them are better adaptable for certain use cases. So the sensors would be better for controlled environments, such as monitoring the employees that I agree to be monitored. So a few funny things happened here, right? So, for example, when you deploy cameras, you should check for the doors, even those that are locked, because it turns out there was a camera at one place, and then there was a door that kind of closed the camera, as people would open that door. When we set everything up, the door was locked, so we thought nothing is going to happen there, but it happens. As we were, testing the system, we were walking around there. So we were part of the data, which is kind of not good because it's not the natural environment anymore, because we are kind of like unexpected people there, not the usual people. And finally, it could be that some people think that they need electricity more than we do. So they would unplug our camera and they would plug their own thing in the power outlets, because I don't know why, but we lost data on that day. And when we talk to the people, when we say, oh, we're going to give you the sensors, you're going to wear the sensors, there were quite a few people who would refuse because they would feel offended if we name them as sensors, and they would feel that, oh, they're going to be monitored and profiled and then whatnot, right? So it's not just about technology, it's also about how to approach people, how to deal psychologically with people so that, they would participate, because it's for their own health anyway, right? Now, the funniest thing probably was that there was one person from the employees who work there, he would ask, what is that camera radiating? You know, ever since you put it out there, it's much harder to work here. The funny thing is that the camera does not radiate anything. It just, you know, takes a picture. It actually, you know, we know how cameras work, right? There's nothing coming out of the camera. So again, psychology is there, how to communicate that everything is safe. And even then people may make up their own minds and say that, oh no, this is not good for me. I don't want this kind of system with us. All right. So we did develop the video and the smart sensors, the ultra-wideband sensor systems. We figured out that they are useful in various environments. And we used two kinds of smart sensors. And we found out that one of them was kind of a turnkey solution where you just place it there and it works. But unfortunately, it wasn't not as elastic as we would want. We could not change all the parameters that we wanted. The other one was developed by us. So that was working. In a sense, it was more elastic. We could do all kinds of custom measurements and things, but then again, it was not as stable as a commercial version. Well, that's to be expected anyway. And in the end, for this kind of problem, we need a system that does both things, that does both visual and the sensors. All right. So we have one more case to consider. So this is about the air quality measurements, again for minimizing the risk of infections. Right? So this particular project was called 3T Concept, and the idea there was to do good for tracing, testing, and treatment of COVID-19 or infections in general. Right? So the focus in this case is going to be on tracing. But we are going to trace not the people, but this time we're going to watch what are the air conditions, right? And if the room is not well ventilated, then there's a high chance that the virus is still in the air, or at least the concentration of the virus is higher than otherwise. So how could we monitor that, right? What's the impact of this kind of approach? Well, if we look at the right picture here, you could see that if we do no action for the exposure reduction, meaning that if we monitor and if there is a risk of infection, if we do nothing, then after 10 days or 60 days, we can have, from one infected person, we could end up having 400 infected people, right? However, if we do the 50% exposure reduction, so then from one infected person, we would end up having maybe 15 infected people. Or if we do 3/4 of exposure reduction, then we really go down from 1 infected to 2.5 infected people in 60 days. So there's a huge difference between 400 and 2.5 infected people. So maybe 3 infected people. What can we do to achieve that goal, to minimize this risk, to save those 400 people so that they don't have to be infected and suffer, or maybe even die? So the solution for this project that we came up with was to create an infrastructure for the sensor data, the air quality sensor data collection, and the analysis system. The idea here is that there are sensors in the environment, that they are communicated the data in real time to the database, and also in real time we can provide sort of plugins that are monitoring this situation. And these plugins, this real-time analysis, can place the information in the dashboard. So you could imagine that every room has like red and green signals. That green means that the air quality is good, or red means that, hey, there are either too many people or the air quality is not too good. You should ventilate the room, or maybe you should even run away from that room, go away from that room, right? So all that is going to impact the people. So this could be also through the web portals. And there was also a mobile application created for that, for personalized risk calculation, so that everyone who participates in the system, they could get, individual information about his own risk at the moment. And then you could monitor if you are in the room. If the risk is high for you, then you better leave. Right? So that's kind of a system that we developed. Right? We used ARANET sensors. So this is a company that's actually in not just in Latvia, but they're selling all over the place, all over the world. Their sensors, they're quite popular these days. And this sensor would measure CO2 levels in ppms, and it would measure temperature and humidity as well. Okay, so and a few other things that I'm not going to talk much about it, right? So we would have a lot of these sensors. Let's say in one of the applications we had them in a unit, COVID-19 unit in a hospital. So basically having the rooms where the patients are, and then the corridors in between, and the rooms for procedures, for medical procedures, and things like that. We would monitor air quality in this kind of environment, for example, right? And that's pretty important because even for the medical personnel, even in the hospital, there were cases of infection of medical personnel. So it's good to make sure that the environment is safe, not just for the patients, but also for the medical personnel, for the clinicians. All right, so there's going to be a couple of diagrams with the data. So in these diagrams, the CO2 is usually in blue color, the temperature is red, and humidity is green. I'm not going to talk too much about humidity, but let's say CO2 is usually correlating a lot with whether the room has to be ventilated or not. So if it's under 1000, then it's probably okay. If it's above, then it's way too bad. It has to be ventilated, right? So in this picture, this is the place where we would monitor the temperature. Let's look at the temperature. And all of a sudden, for a couple of days, the temperature jumped from 24 to almost 28 degrees. So this is the area in the picture where you exit the COVID-19 zone. So this whole area is called the red zone, meaning that you can get there only through a gate, only if you are properly, dressed in a protective suit and everything. So when you leave the area, then you leave, there's a shower and decontamination room, basically, right? So that's the sensor next to the decontamination room, apparently. And all of a sudden there was for a couple days, there was something wrong with the, ventilation or with the heating system. And then a few days later, the same thing happened. So apparently, if we have a system like that in place, then we can monitor for these kind of events. We can alert the proper facilities that can go and fix what was wrong with that. Because turns out, according to the law, you're not even allowed to work in such high temperatures. Speaking of hospitals, If we're looking at some other pictures, so let's say here is one room. So this is a patient room. Everything seems to be nice under 1000 here, except there's a one peak for one day. And we found out that some other rooms also had the peak at this day. So apparently on this day, there is a problem with the ventilation at large in the hospital, or at least in that unit. Again, this could be used as an alarm, and we could quickly go ahead and fix it so that there is no more problem with the ventilation here. All right. In contrast, if we look at a person who is working in a cabinet, so this is sort of like an office worker, one of the in the hospital institute next to the hospital, then you can nicely see how the CO2 levels with every day through the week go up, and then they go down for the weekend, and then they go up, and so on. So here the levels are going above 1000 for quite a few days. So that's not too good. So again, we could help that person, to aid that person, to help them to ventilate the room more often. Okay. So now these pictures are looking at only 24 hours. However, we are having a cumulative data here from many days over those 24 hours. So this basically gives us the perspective of how things are time-wise throughout the day. So it looks like that in the morning, there's ventilation kicks in and there's a lower CO2 levels, and then at night as well, before the night, but generally everything is kind of level and below 800 even, right? So that's a good sign in this room. Now if we're looking at another room, so this is room 209, so this is 215, So here the ventilation is maybe not so great, but it's still under 1000, right? But we do see the difference here. So it's telling us the story that something maybe could be done here. If we look at the map, then these rooms seem to be, one is more on the north and the other is more at the south. So maybe the environment, the weather is impacting. So this data. So this data comes from, it was, there were sunny days as well, right? It was not all gloomy. So this comes from between January and March, including, roughly, right? Now we can also look at two different rooms. So this one is the picture on the right is the room for the office worker. The picture on the left is a nurse post in the hospital, basically, right? And we can see that here things are good at 800 level, while here the things are not good. They are above 1000 level. And even in this picture, we can see that at night everything seems to be fine, but during the working hours, the ventilation needs to be improved. So we could actually save some money on the ventilation and not do so much ventilation during the night hours, but during the day we need to properly turn it on if we want everyone to be healthy in our hospital. Another thing that we did, we created what's called a probability calculator. So this calculator is based on one publication that proposes a way to calculate the risk of infection based on all kinds of parameters, including a number of people in the room, including the time, the size of the room, the percentage of people wearing masks even, right? And also the parameters that we got from the air quality measurement, right? So based on these parameters, we can calculate even in real time or by hand what is the risk of infection in these conditions, right? And that can help us to figure out whether this room seems to be fine, whether there's a high risk room and something needs to be done about the air quality in that room, or maybe about how many people are in that room, right? So conclusions number 3 for this project. If we do air quality measurements, they are relevant, they are telling stories, both in short term, we have an event, we can respond, and also in the long term, if we look at those, interleaved aggregated data pictures, how we could save energy, for example, with reducing the ventilation at night, but increasing during the day, perhaps, right? And also, of course, we can lower the risk of infections using a system like that, right? And once again, technologies alone are not enough. We need psychological support. So one example of what I remember is there was a room for the young residents. There were a lot of people there. And there was, again, the CO2 levels were pretty high when we placed sensors there. And they noticed that, and they would immediately go and open the windows and they would ventilate the room. And it would go like that for about 2 weeks or so. And then they would kind of just get used to the bad numbers and would not ventilate anymore. So as people, we are kind of getting used to bad stuff, unfortunately. And that's bad for all health in some cases, right? So again, we need to do some psychological intervention there so that people would remember to still ventilate, to still comply with the, or maybe we can somehow do a gamification to improve these results. All right, so all in all, for today's talk, what are the takeaways? I would invite you to consider sharing data for the sake of, improving digital health, not just for us, but also for our children. Even if whether we have problems or not having problems, if we could share our data with the research doing this or that study, right? It could be related to measuring heart rate or temperature or whatever, or it could be related to measuring distance and contact tracing, things like that. Then it can tremendously help our quality of life and our health, right? But of course, we need to deal with the privacy. It's not okay to just disclose anybody's data. A lot of that seems to be going on in China these days. The privacy is not such a big issue there, at least from my subjective opinion. But let's if we are in position to actually do something about it, do not forget about the privacy, right? And if you are in business of IT or tech or engineering, I encourage us to create the data sharing tools and analysis and tools for digital health. If you are a policymaker or in that kind of world, then please do consider the benefits that these solutions can do and create environment for digital health to be accepted and practiced, right? Right. And then what I'm saying is find the joy in giving up some privacy, the joy of healthy children, because whenever we give away our data, we are giving away some of our privacy, right? But the benefit might be good for our kids. All right. So in the end, human factor, we make mistakes, doctors make mistakes, everybody makes mistakes. Digital health can help to avoid those mistakes. Digital health can help to improve the quality of service. Right? Digital health can help taking more measurements than just once a year, maybe blood test or something like that, right? And improve the big picture and help with actually treating people and improving our health. It is also important, very important, to follow the patient's journey, how the patient feels as he goes through these solutions, be it digital health or the regular hospital environment. And there's a lot to be done as well, right? And as I said, sharing the data is both power and also the responsibility. So what can you do to help? So this is the lecture for today. If you have any questions, I'll be happy to answer. Otherwise, thank you for watching.